Hi, my name is Rachel Bentley, and I'd like to talk to you today about the impact of family presence in the MICU, developing family witness cardiac resuscitation education. The problem identified relates to cardiac resuscitation or CR in the MICU and the lack or limited availability of resources for the clinical team to provide family adequate education to prepare for a crisis or deterioration situation. It is particularly challenging for the families due to their unfamiliarity of the ICU setting and lack of clinical knowledge related to CR. Instead of decision-making occurring on the spot or when a crisis situation occurs, families need to be informed of the CR process and given options to support their loved one's wishes. More than 41 million visits to the ED and 2.5 million hospital admissions occur annually, with millions undergoing resuscitation and surviving traumatic injuries, creating major life changes for families. Patients' families are deeply affected by this issue due to an unfamiliarity of the ICU setting and what CR involves. However, being present during CR may help family members understand all life-saving measures were implemented in the attempt to bring their loved one back to life. The purpose of this project is to implement education using a clinical practice document related to FPDR or family presence during resuscitation to meet the following objectives: to improve family decision-making, to improve patient care, to increase family coping after patient experiences resuscitation, reducing anxiety and stress, and to improve communication between families and the clinical team. The project will take place at UK Healthcare on 9 Medicine ICU or 9 MICU. All family members of appropriate mental health of patients requiring resuscitation who previously received the education during the 4-week project trial period will be identified for recruitment into the study. Significance to advanced nursing practice. CR frequently occurs in the ICU environment. AACN's expected practice supported by evidence-based research advises an approved written practice document, for example a policy, procedure, or standard of care, be presented to a patient's family allowing the option of presence at the bedside. This problem is significant because despite support by professional organizations such as the AACN and critical care experts, a mere 5% of U.S. critical care units have a written practice document permitting and encouraging family presence in place. In reviewing current research results, the intervention of FPDR was highly supported in all control trials and case control studies to improve communication and advocate the value of having written family presence policies in place. FPDR was also associated with positive results on psychological variables and did not interfere with medical efforts, increase stress in the healthcare team, or result in medical legal conflicts. It was determined relatives who did not witness CR encountered anxiety and depression more frequently than those who did witness the process. Overall, resuscitation effectiveness was not affected by the presence of family member, nor was the duration of CR, the selection of drugs, or the survival rate. Those who participated in the FPDR option experienced reduced anxiety and stress and fostered family reports of well-being. In order to cultivate a spirit of inquiry, the principal investigator, or PI, will ask for volunteer focus group members, with peers, management, physicians, and leadership, on the MICU to evaluate current policy and procedures relevant to FPDR. Volunteer members would become a part of the project team. The PI will also consult with ED staff to evaluate protocols in place due to the high volume of cardiac arrests that occur in this setting, and review further literature focused on current outcomes of practice. Upon research and focus group completion, the PI will create an education, informed consent, and survey form. The provider, resident physician, or nurse practitioner will approach families upon MICU admission to provide FPDR education using a verbal script. All providers will receive education using the education form. The education form will acknowledge family members receiving the education. At this time, the provider will ask families who agree to FPDR if they'd like to voluntarily be a part of the research project, including being surveyed upon hospital discharge if their loved one experiences cardiac resuscitation. The informed consent form will explain the project's purpose and ensure families understand the project is voluntary. This form will also require family contact information to complete. If family members agree to participate in the project, the informed consent form will be signed and retrieved at this time. The provider, witness, and project participant must all sign the informed consent form. The consent form will then be documented by the PI upon consent sheet retrieval. All providers securing consent will be required to turn in consent forms to a designated supervised area to maintain confidentiality of all project participation. After securing informed consent, the PI will then use chart review to retrieve cardiac resuscitation data and also reach out to charge nurses. They need to contact or inform the PI of CRs occurring on the unit during the 12-month period. The family contact information will then be used to send post-implementation survey to all project participants. All adult family members of medicine ICU patients who received clinical practice document on FPDR education before cardiac resuscitation occurred during the 4 weeks of project trial will receive post-implementation survey. The survey form will use a Likert scale to report data focusing on medical decision-making, patient care, coping, focusing on anxiety and stress, and communication. The principal investigator will create survey form to include decision-making and patient care questions and use a family crisis-oriented personal evaluation scale, acute stress disorder scale, and family problem-solving communication index scale to evaluate coping, anxiety, and stress. The survey form will then be collected over a month time period to measure outcomes and perform data analysis. Family involvement is continuously promoted. However, documentation is not available and education regarding FPDR rarely occurs in the MICU. When it does take place, it's often too late and the clinical team is already in the midst of performing cardiac resuscitation measures on the patient, which creates a very chaotic time for family to absorb the situation. A written clinical practice document providing families education before a cardiac resuscitation event occurs has the potential to improve outcomes of care in the MICU, reducing anxiety and stress, and improving communication between the clinical team. In order to promote both patient and family-centered care, staff, providers, management, and leadership must acknowledge this National Priority Practice Award and advocate implementation of FDR intervention education and use of standardized policies and procedures. Thank you for your time.